Welcome to The Explainer. Today we're doing something a little different. We're going to step right into the pressure cooker of a surgical oral exam. I'll be playing both the examiner and the candidate, walking you through a tough clinical case. The goal here is to show you the thought process, what it really takes to pass. So, let's get started.
So here's our roadmap. We're going to follow this case from the very first presentation all the way to the final debrief. We'll cover how to work up the patient, make a decision, go to the OR, handle complications, and then, most importantly, we'll break down the key takeaways that'll help you ace the exam.
All right, picture this. You're in the exam room, heart's pounding a little, and the clock is officially ticking. I'm your examiner. Let's begin the viva.
Good morning, candidate. We'll start with this. You're asked to see a 62-year-old man who's been having 3 months of just vague abdominal pain, some nausea, he's lost weight, and he's anemic. Tell me, how do you proceed?
Okay, thank you. So my approach here would be really systematic. I'd start with a detailed history and a thorough physical exam to start building my list of possibilities, my differential diagnosis. And from there, I'd move on to some more targeted investigations. With symptoms this vague, you really want to cast a wide net at first.
So in terms of my differential diagnoses, the most worrying thing on my mind is a malignant small bowel tumor. That could be an adenocarcinoma, a neuroendocrine tumor, a lymphoma, or a GIST. But, I wouldn't want to get tunnel vision. I'd also keep things like Crohn's disease, maybe even something infectious like intestinal tuberculosis, or a vascular problem like chronic mesenteric ischemia on that list.
Good. A solid differential. Now, before we jump to ordering scans and tests, tell me, what are the major risk factors for primary small bowel tumors?
Of course. Well, the big ones that come to mind are genetic cancer syndromes, things like FAP or Lynch syndrome. Then you've got chronic inflammation from conditions like Crohn's or celiac disease. That's a huge one. Even structural things like a Meckel's diverticulum can be a risk factor. And of course, lifestyle factors like diet, smoking, and alcohol use play a role.
Excellent. So, you proceed with the workup. A CT scan confirms there is a mass in the small bowel. You manage to get an endoscopic biopsy, and the pathology report comes back, it's a gastrointestinal tumor, or GIST. Now, how does this specific diagnosis change your management plan, especially when you compare it to something more common like an adenocarcinoma?
That is a fantastic question and a really crucial distinction. With a GIST, the #1 surgical goal is to get the whole thing out, with the capsule completely intact. If that capsule ruptures, the prognosis gets a lot worse. And importantly, you don't usually need to do a lymphadenectomy because GISTs don't typically spread to lymph nodes. The follow-up therapy is with tyrosine kinase inhibitors, or TKIs. Now, for an adenocarcinoma, totally different ballgame. You need a wide resection to get negative margins, and you have to do a formal lymphadenectomy, get at least 8 to 10 nodes, and the adjuvant treatment there is standard chemotherapy.
Okay, so for this patient with the GIST, surgery is the main event. But the really big question, the one that changes everything, is whether he needs adjuvant therapy afterwards. And that decision hinges entirely on the tumor's risk of coming back. And we figure that out by looking for high-risk features. So what are they? Well, we look at the tumor size. Is it bigger than 2 centimeters? We look at the mitotic index. Is it high? Did the tumor rupture during surgery? And were we able to get it all out with clean margins, what we call an R0 resection? Any one of these puts the patient in a high-risk category and is a strong reason to start adjuvant therapy.
And I want you to zero in on this number for a second. More than 5 mitosis per high-power field. This is a critical threshold. It's one of those facts that every surgical candidate has to have locked and loaded because it directly tells you whether to give adjuvant therapy, and it seriously impacts the patient's long-term outlook.
All right, candidate, you've made your plan. You're heading to surgery. Take me into the operating room with you. Talk me through the key steps of a small bowel resection for this GIST.
Right, so after we have informed consent and the patient is prepped, I'd start with a midline laparotomy. First thing I'd do once I'm in is a systematic exploration of the whole abdomen, just to make sure there's nothing else going on. Then, I would carefully isolate the piece of small bowel with the GIST, along with its blood supply in the mesentery. I'd place soft, non-crushing clamps on either side, divide the mesentery, and then resect that whole segment. And finally, I'd reconnect the 2 ends of the bowel with an anastomosis to restore continuity.
A very clear plan. Now let's throw a wrench in the works. During the operation, you notice that the bowel just upstream from the tumor is very dilated and swollen. What is the significance of that finding?
Whoa, okay, that's a huge intraoperative finding, a massive red flag. It immediately makes me worry about the safety of my anastomosis. Trying to sew together dilated, unhealthy bowel is just asking for a leak. So patient safety comes first. My plan changes on the spot. I would still resect the tumor, but instead of reconnecting the bowel, I'd bring it out as a temporary stoma. We can always come back and reverse it later when the patient is recovered and the bowel is healthy.
A very prudent decision. But for the sake of this exam, let's change the scenario. Let's say you did proceed with the anastomosis. Now it's post-op day 7. The patient's wound starts draining intestinal contents. You've got an enterocutaneous fistula. This is a major surgeon-caused complication. How do you handle it?
Okay, managing a fistula is all about having a structured, step-by-step approach. You can't rush it. Step 1 is stabilization. That means fluids, correcting electrolytes, getting nutrition in, usually with TPN if it's a high-output fistula, and most importantly, controlling any infection or sepsis. Step 2 is investigation, using a CT or a fistulogram to map out the anatomy. Step 3 is making a decision to try conservative management and setting a realistic timeline. If it doesn't close on its own, then Step 4 is definitive surgery, but, and this is key, only after 3 to 6 months. You have to let all that inflammation cool down. And the final phase, Step 5, is rehabilitation.
And the whole reason for this patient-deliberate approach is because we know there are specific things that prevent a fistula from closing on its own. We're talking about things like malnutrition, ongoing sepsis, underlying diseases like IBD or cancer, or if the patient has had radiation. Then there are factors about the fistula itself, like if there's a blockage downstream, if it has a really high output, over 500 mils a day, or if the tract is super short. You have to address all these things before you even think about going back to the OR.
And this number right here, this 30%, is exactly why we're patient. The data tells us that if you do all the right things, control the sepsis, get nutrition in, protect the skin, about a third of these fistulas will actually close by themselves. Rushing an unstable, malnourished patient back to surgery is almost always the wrong move and often leads to an even bigger disaster. Excellent. That concludes our scenario. You've navigated a pretty complex case, from the initial vague symptoms all the way through to a life-threatening complication. Your answers really showcased some of the most important elements of a successful Viva performance. Let's break those down.
So, look, passing a Viva isn't just about spitting out facts. It's about how you think and how you communicate that thinking. You see what we did here? We started with a broad differential, then we narrowed it down with more information. Every plan had a clear structure: investigations, management, complications. We used key criteria, like the high-risk GIST features, to back up our decisions. And critically, we verbalized the red flags, like the dilated bowel, and always put patient safety at the center of every decision. That's the blueprint.
Okay, let's boil it all down to the absolute high-yield facts from this case that you need to take away. 1. Know the difference between GIST and adenocarcinoma. Capsule intact, no nodes for GIST. 2. For fistulas, the mantra is simple: stabilize, investigate, and only then do you operate. And 3, dilated bowel is a major danger sign. It screams high risk for an anastomotic leak. Don't ignore it.
And we'll leave you with this final thought. When you're dealing with a real mess, a complex surgical complication like a fistula, what's more important? Is it having the raw technical skill in the OR to fix a difficult problem? Or is it having the wisdom and the patience to spend months optimizing that patient, getting them into the best possible shape before you even pick up a scalpel? That's really the heart of surgical judgment. Something to think about.